All right. Well, we are just at 8 a.m. Happy fall, everyone, and happy homecoming weekend and upcoming Halloween. Delighted to have our own Dr. Ed Vasilevskis presenting at Grand Rounds. And to introduce Dr. V, we have Dr. Blair Golden, one of our faculty members in the Division of Hospital Medicine. So Blair, I'll hand it off to you.
Great. Good morning, everybody. So very excited to introduce Dr. Vasilevskis today as one of my mentors. He obtained his MD from OHSU and completed his internal medicine residency at UCSF, where he then also served as a chief resident and completed a general internal medicine fellowship. He then spent 15 years on the faculty at Vanderbilt before joining our faculty at UW as our hospital medicine division chief last year. While at Vanderbilt, he held multiple leadership roles, including serving as a section chief for hospital medicine, as well as their internal medicine clerkship director for a number of years. We were thrilled to recruit him because of his national leadership in hospital medicine and research on measuring and improving the quality of care for hospitalized older adults. His research has focused on key areas of delirium, polypharmacy, and care transitions, some of which he'll be speaking about today. He recently completed an NIA R01 pragmatic clinical trial to reduce medication use amongst hospitalized patients discharged to over 20 post-acute care facilities, and his current multi-site pragmatic clinical trial, Behavioral, Economic, and Staffing Strategies to Increase Adoption of the ABCDEF Bundle in the ICU, is funded by an NIH UG3 UH3 grant. So with that, Ed, I will turn it over to you.
Great. Thank you so much for that kind introduction. Thank you, Dr. Schnapp and department for inviting me to present at Grand Rounds. It's wonderful to be here. I'll be talking about some of that work that Dr. Golden mentioned about our SHED-MEDS trial and focusing on polypharmacy, but also the notion of polyproviders and polypharmacies and what we can do in the acute care setting to help reduce some of the medication burden that our patients are experiencing. See if I can advance. Hold on. There we go. Conflicts. I did have a consulting relationship with Gilead, but it will be irrelevant to what I'm discussing today. Just a first thing, I'm new to University of Wisconsin. I've been here for about a year, so this is a wonderful opportunity for me to introduce myself to the department. This is a nice little word cloud that summarizes my research over the last 15 plus years in my work. You can see medicine and hospital are pretty big. Deprescribing, older, geriatric, delirium, quality, nursing, readmissions, critical care. And so I'm going to be talking to you predominantly about some of my work in care transitions in polypharmacy today. The objectives, first, we're going to summarize some of the risks of polypharmacy among hospitalized patients, including medication discrepancies. We're going to discuss the efficacy and safety of deprescribing in the acute care setting. We're going to identify common indications for deprescribing medications, and then we'll summarize patients' attitudes towards deprescribing in the inpatient setting. First, I want to start with a case. This was a patient that I saw. It was a 54-year-old woman with a history of lupus, complicated by lupus vasculitis, PTSD, a questionable seizure disorder, was unconfirmed, chronic pain syndrome, and 10 days prior to admission, the patient developed some right greater than left pleuritic chest pain. There was no fevers or cough. And on the morning of the admission, the patient felt lightheaded, and then the patient's hip gave out, and she fell on her right side, falling directly on her chest. There was no loss of consciousness, and she had immediate right-sided chest pain. Her EKG was normal. She had a negative troponin. She did have a CTA, had no PE, but it was notable for multiple right-sided rib fractures. She had a TTE that was negative for pericardial effusion. Rheumatology had been consulted, and they felt there was unlikely a lupus flare that preceded this event. And the pain team at the time that I saw them was predominantly involved for acute pain control due to the rib fractures. I took over the patient on about day 4 of hospitalization from a fellow hospitalist. And this was the medication list for which I was presented with. There are 31 total medications. In green were new medications. So on day 4, over the first 4 days, these were some new medications that were added: acetaminophen, dapsone, enoxaparin, lidocaine, and a multivitamin. There were some held medications, just one, naproxen. And then there was a whole host of additional medications for which the patient was taking prior to the hospitalization. And you can see there's a whole host of medications which we would consider potentially inappropriate, which we'll talk about in a little bit. Things like clonazepam, patient was on a long-acting fentanyl patch, patient was on methocarbamol, prednisone at a pretty high dose over long term, pregabalin, and temazepam, just to name a few. Now, I think all of us could look at this list and say, I think this patient is experiencing polypharmacy. And this is something that we see quite commonly in the acute inpatient setting. And so next, we'll talk a little bit about polypharmacy in the context of acute care and hospitalized patients. First, what is polypharmacy? There is no true standard, gold standard definition. However, you will commonly see either 5 or more or greater than 5 medicines generally accepted as the definition for polypharmacy. If patients are taking more than 9 medicines, they'll often be called hyperpolypharmacy or excessive polypharmacy. So you'll hear me talk a lot about polypharmacy or hyper or excessive polypharmacy. Now, we know quite a bit about the prevalence of polypharmacy. This just summarizes essentially over 106 different studies looking up to 2019 with regards to the prevalence of polypharmacy across multiple different settings. Across all settings, polypharmacy was present in about 40% of patients, that definition being greater than 5 or greater medications. However, this looks at the subgroup of population in the acute inpatient setting, which you can see there's an increase in the degree of polypharmacy among those patients. And here, the median essentially was 52%. Now, not all medicines are created equal, and something that we focus a lot on, both in hospital medicine, primary care, and geriatrics, are what are known as potentially inappropriate medications. Oftentimes, these medications are defined via explicit criteria from various publications, which many of you might be familiar with. The most common one is what's known as the Beers criteria, published on a regular basis through the American Geriatric Society. And you can see there are regular updates if you look at the first and the second and third rows, 1991, 97, 2003. And what you can see are essentially the number of studies according to the various explicit criteria, whether they be Beers. There's something known as the start-stop list, which is just another criteria having potentially inappropriate medications. And then there's some study country-specific tools which are also identified. And you can see that the pooled prevalence among patients having at least one potentially inappropriate medication in the inpatient setting is anywhere from 32% to 72%, depending on what tool you're looking at and how we're defining it. Now, how did I get interested in this topic? It goes back, I'm going to tell a little bit of a story of my research in transitions of care as well as polypharmacy. Some of you may remember in 2008, we had a bit of an economic financial crisis, and there were some calls for grants through the CMMI, the Center for Medicare and Medicare Services Innovations Grant. And we were particularly interested in improving the transitions of care from the hospital to the skilled nursing facility setting. And what we noticed was that there was a number of interventions which improved transitions to skilled nursing. There was another number of interventions which focused on transitions from the skilled nursing facility back to the hospital, but really nobody had put this all together. So we created something called Impact Interact, improving post-acute care transitions, and Interact, building on Joe Ausliner's work, really looking at standardized processes for evaluating skilled nursing patients and assisting with their transitions back to the hospital. Now, what did we do? We essentially enhanced communications among the hospital as well as the skilled nursing facility. We systematically identified geriatric syndromes and communicated those across those settings. We gave recommendations for the care across the settings. We did medication reconciliation, really making sure we had the correct list at the time of discharge. And we did rehospitalization reviews. And what was striking to us after all was said and done, we initiated the study around 2013. And after the conclusion of the study, we noticed that, gosh, our patients that are being hospitalized and going to skilled nursing facilities, they're on a lot of medicines. In fact, I showed you before the prevalence was 52% for polypharmacy among hospitalized patients. Well, among this population of hospitalized patients who go to post-acute care, 98% of our patients met the criteria for polypharmacy. In fact, we had a sister study done through the VA, and we found exactly the same thing. 83% of our patients met the definition for hyperpolypharmacy, taking more than 9 medications at the time of skilled nursing facility discharge. Well, in fact, the number of medications, the median at discharge from the hospital was 14, and by the time they left the skilled nursing facility, the median number of medications was 15, and there was about 5 changes. And so the total was 15, but there was a lot of plus and minus throughout the hospitalization. And of course, once again, not all medications are created equal. We looked at those potentially inappropriate medications, and we found that there was a mean of about 2 medications at hospital admission and 2 at discharge. And once again, there were some changes to these medications throughout the hospitalization. So although we were really focusing on getting the right list, meaning that we knew we were getting the correct medications from one site to the other, what we really were focused on was, gosh, do they need all these medicines? And we had not been doing that as part of this Impact Interact. And that got us really thinking about deprescribing and the role of reducing medicines in acute care. Another reason why we were really concerned about this was we created this list called the medications associated with geriatric syndromes. And the PIMS list via the Beers and the start and stop criteria, they often do not include chronic medications for which patients take for chronic comorbidities like diabetes or hypertension. However, some of these medications can certainly be associated with geriatric syndromes. Now, some medications are bigger offenders than others. We looked at a whole host of geriatric syndromes. Here, you can see we measured cognitive impairment, delirium, depression, urinary incontinence, weight loss, and falls. And what we did was we created a list of medications that were associated with each of these syndromes via an evidence-based medicine and the use of experts. And the most offending medication, the one that might hit all the syndromes, actually turned out to be anti-epileptics. So those would be associated with each one of these conditions. However, what you can see is among our patients that started in the hospital and went to the post-acute care setting, there was a mean of 5.9 medications which were associated with a geriatric syndrome. Falls was by and large the most common, for which there was 5.5 medications which were associated with a geriatric syndrome. However, they were widely prevalent across a number of geriatric syndromes. So you start to wonder, gosh, I wonder, we know that polypharmacy is potentially bad. I wonder if we deprescribe and reduce those medicines, can we create some benefit from a perspective of geriatric syndromes? Now, what do hospitalists think? I work in the hospital. My colleagues, we deal with these medication lists on a regular basis. I once gave a presentation to a group in Nashville with regards to the role of polypharmacy in acute care. And I asked them, how would you describe your patient's medication list at the time of hospital discharge? And this is, you can see I like word clouds. This was another word cloud that was created. And you can tell it was done in the South because hot mess came up near the top, and hot mess is a very beloved Southern term. However, other terms, excessive, complex, duplicates, chaotic, superfluous, whittled. So those feelings that our research team were having with regards to, we feel like these medication lists are excessive, potentially some medications are superfluous, we clearly were not alone. The general providers, in terms of hospital providers, are feeling much the same way. Well, let's talk a little bit about the risks of polypharmacy. I think many would probably agree that the number of medications I showed you in that case is too much, but there has to be a reason why we care. What is the burning platform? Well, one of the things that our team has been focused on a lot is medication errors, and specifically, how do we do a better job of med reconciliation? And what I show here first is one thing that happens as you get more medicines, you get more mistakes. That's just logical. It makes sense. The more opportunities you have for error, the more your denominator is. What we did is essentially try to quantify among this population who start in a hospital and go to skilled nursing facilities, for every additional medicine that these patients had, there was a 20% increase in a risk of a medication discrepancy. And a discrepancy could be an omission, meaning that the patient was taking it at home, but we didn't know they were taking it. The discrepancy could be an addition, meaning that we added a medicine that we thought they were taking at home, but in talking to them, it turns out they're not taking the medication. And finally, discrepancy can be a dose discrepancy where we just had a very different dose of the medicine that we both agreed that you were taking. Now, this will quantify some of those discrepancies among this population, among patients who start in the hospital and go to the home. What I'll show here, first of all, is among this population who have an average, once again, of about 16 medications going to the post-acute care setting, there was a discrepancy in about 4.5 of those medicines, a mean and a median of 3, with an interquartile range of 2 to 6. Omissions were by and large the most common cause for medication discrepancies, and this has been borne out from other acute care studies which are outside of those patients going to skilled nursing facility. Once again, about 2 medications that our patients are taking that we actually didn't know they were taking until we did a better job about doing a medication history. And I'll talk a little bit about how to do that in just a bit. Now, in addition to just getting it wrong, of course, with discrepancies, we make errors. I'm not going to show data, but it's very clear that same study I showed with the prevalence of for potentially inappropriate medications, they also showed that those potentially inappropriate medications are associated with adverse drug events, with drug-associated readmissions. And here I show something called the drug burden index. And this is something we use in our research, but I think it's something very valuable when it comes to talking about deprescribing. And the drug burden index essentially is just a measure of essentially how many anticholinergics and sedative medications that they're on. And the higher the dose, the higher your score. And the big D is essentially the dose that that patient is taking. And you can see the sigma sign, that is the lowest, safest dose, which is recommended by the Food and Drug Administration. So to give you an example, if someone is on the safest, lowest dose, they will have a drug burden index of 0.5. So every safest, lowest dose of an anticholinergic and sedative medicine, you're going to get a 0.5 added to your drug burden index. So if you're on 4 low-dose medications that are of the safest, lowest dose of an anticholinergic sedative, your DBI is going to be 2. Now, if you're on a really high dose of an anticholinergic or a really high dose of a sedative medicine, well, now your DBI is going to be asymptotically up to 1. So the highest dose is 1, so you get a DBI of 1. So if I get put on a very high dose of Benadryl, I'm going to get a DBI of 1. And if I'm on a regular low dose and a safest dose of a benzodiazepine, I'll have a 0.5 and I'll have a 1.5. Now, this is really helpful from a standpoint of deprescribing. And one of my mantras is deprescribing doesn't have to mean stopping. Dose matters. When you think about deprescribing, don't just think about stopping medicines, because we know for every unit increase in DBI, there's a 37% increase in mortality among those patients 65 and older. For every unit increase, there's a 35% increase in the length of stay in the hospital. There's a third increase in hospital admissions, and the rates of fall-related hospitalizations goes up by 50% as well. There are a whole host of other studies looking at DBI and showing lots of other additional adverse outcomes, specifically with cognition, delirium, et cetera, et cetera. So I really like the DBI. It's great from a research perspective, but it also just reminds me that, once again, dose matters. And when we think about deprescribing, reducing the dose is important. You're going to get some bang for your buck. This is just another example of where dose matters. I like this study because I also like to talk to my patients about the potential harms of their medication. Something that our patients care a lot about is their cognition, and they may have some appropriate fear and concern about future changes in their cognition and the development of dementia. This was a nice study that was done out of the group health in Seattle, where they followed 3,500 patients for 7.5 years. And they followed essentially their anticholinergic burden. You can see in this table, there's a total standardized daily anticholinergic dose. This is just another kind of drug burden index, but they do it on a daily fashion. And what's most important for our purposes is that the higher number means the more kind of burden they have with exposure to anticholinergics. And they followed these patients. None of them had dementia at baseline. They would do regular cognitive screening. And for those patients who screen positive, they would then go to a neurologist or psychiatrist or a geriatrician, and they'd have rigorous evaluations for dementia. And so they were capturing incident dementia. In the meantime, in their studies, they controlled for incident heart disease, stroke, history of depression, current benzodiazepines, and these were entered as time-varying covariates, really to try to get to the independent effect of those anticholinergic burden. And what you can see is for that highest dose, as an example, there was a 50% increase in the risk of incident dementia. Well, what is the highest dose for those of us who are clinicians and don't think about TSSDs? A high dose would be greater than 3 years of oxybutynin at 5 milligrams, or olanzapine at 2.5 milligrams, or meclizine at 25 milligrams. So these are medications, when I look at them, I go, gosh, I can think of a number of patients that I have seen who've been on these medications for that long period. So what's important in terms of those discussions of deprescribing is, once again, those links to outcomes that matter. That my patient may feel like that I'm not having any problems, but to be able to discuss about some of those future state problems which could occur from long-term exposure. Well, let's flip to deprescribing in acute care. And I'm going to take you a little bit of a journey on my research over the past number of years. Deprescribing, well, what is it? I've been talking about deprescribing. It is the systematic process of identifying and discontinuing drugs in instances in which existing or potential harms outweigh existing or potential benefits within the context of individual patient's care goals, current level of functioning, life expectancy, values, and preferences. This was from Ian Scott, kind of one of the kind of premier researchers in deprescribing. To me, this is just it's the opposite of prescribing. If you just thought about prescribing, you do the same things in terms of taking into context patients' goals, their level of functioning, life expectancies, values, and preferences. We're just doing it in the reverse. Now, I'm a hospitalist, and up to the point that we started this study in about 2017, most of the deprescribing had been done in the outpatient setting. And you might think, well, inpatients, it's pretty, lengths of stay are relatively short. Why should we do inpatient deprescribing? Are there any advantages? And we had some hypothesized advantages. First of all, by definition, the population is at higher risk. I showed you that the prevalence of medications is also higher among these patients. And so generally, when we do interventions, it makes sense to do it among the highest risk populations. Also, I didn't show data, but potentially inappropriate medications are commonly started in the hospital. And so this is an opportunity for us to really try to do also some prevention of that polypharmacy. Third, patients oftentimes come in with conditions for which is linked to their polypharmacy. So when they come in with a fall and fracture, this is a perfect opportunity to talk about their medication specifically related to falls, thinking about that case that I presented to you. If a patient comes in with delirium or altered mental status, another great opportunity to be thinking about the linkage of their medications and having frank conversations with them. In the hospital, we often have pharmacists and a multidisciplinary team to be able to help us through some of the decision making. And some of the medications might require specialty expertise to deprescribe, and it might be more readily available in the hospital. And then, of course, there's concerns. There's fears of deprescribing. What's going to happen if I stop those medicines? And we can monitor patients in the hospital, and that might be something which can facilitate deprescribing. Now, when we embarked upon this study before 2017, there were some deprescribing trials that were done. One that had been done in the United States. Most of them had been done in Europe. And most had focused exclusively on explicit criteria, taking those Beers list, focusing on Beers list medications and seeing if they could reduce those medicines. Limited follow-up. There was none that were focused on post-acute care settings. And overall, if I could just summarize this research, it was, we can reduce potentially inappropriate medications, generally an average of 1. Generally, it caused no harm, and there was really limited outcomes to look for any benefit. So it was deemed that it was potentially safe that we could reduce potentially inappropriate medications in the hospital. Now, since we started our study called SHED-MEDS, and we have another one called DROP-MED, there have been a number of inpatient studies. And one of the biggest ones was something called OPERAM. This was optimizing therapy to prevent avoidable readmissions due to inappropriate medications. This was a cluster randomized trial. It was done in Europe, over 4 European countries and academic centers. They had 2,008 older adults who had greater than 3 chronic conditions and greater than equal to 5 medications. They underwent structured pharmacotherapy optimization, and it was done via a informatics-based program called STRIP, which basically identified medications on the start-stop criteria. They would bring them up to a pharmacist and physician, and these clusters, the clusters were done at the physician level, and those opportunities were presented to them with regards to medications which could potentially be started or stopped, and their primary outcome was drug-related hospitalizations within 12 months. The stop criterias, they really do it by system. They have a drug indication criteria, but then the rest of them are systems-based, as you can see here. It's pretty complicated. You need an informatics-based system to go through the stop list because there's 114 different start and stop criteria in the version 2 elements for which they used. And what did they find? Well, over the course of the study, there was essentially 86.1% of the patients had at least one recommendation, a start or a stop, with a mean of 2.8 per patient at the time of the intervention. 65% of those recommendations were stop recommendations. The rest were, of course, start. And then they looked at the patients at 2 months afterwards, and there was about a 62% success rate at 2 months with a mean of 1.2 medications that were successfully stopped at 2 months. The most common reasons for deprescribing, and this is important and relatively consistent, you'll see it among ours, is that there was no clinical indication for why the patient was on the medication, about 36% of the time. And I can tell you in our research, we found almost exactly the same percentage of number for which the reason for deprescribing is we just can't figure out why the patient's on the medication. Now, they had relatively modest success, a mean of 1.2. One thing I'll notice importantly, and this is a context of our study, which I'll share with you, is that the control setting was just usual care. And why that's important is I'm going to share with you, I shared with you some of those medication discrepancy data. And if you don't do a best practice medication history, what can happen in the control site is that you might be missing upwards of 2 medications that the patient is taking, which you didn't capture. And so some of the reason why there might be a bias of the null in the study is that they did not do a best practice medication history in the control arm. In the end, after 12 months, it was a safe study. There was no harm, but there was also no difference in drug-related hospitalizations at 12 months, which was their primary outcome. All right. The remainder of the time, we're going to talk about the research that we have been doing with regards to deprescribing. I'll remind you that our research is really focused on an important group, but a smaller group of older, frail, older patients who are going to skilled nursing facilities. We had 2 trials. One is called SHED-MEDS. I'm going to spend most of the time talking about SHED-MEDS. Another one was a VA study, which we are just wrapping up, called DROP-MED. It's the drug reduction in older persons. Importantly, the populations are essentially the same. One of the key differences, which I'll highlight, is in SHED-MEDS, we continued deprescribing in the skilled nursing facility. In DROP-MED, we did not. We just provided them recommendations in the skilled nursing facility, but did not do active deprescribing. And I'll show some reasons why that might be important in a second. Now, when we designed this trial, we really looked at the evidence and we said, first of all, there is really no work that had been done in this area of this population going to post-acute care. And there are some potential real benefits of doing post-acute care interventions, and that is that they're there for a couple of weeks. So if you're interested in deprescribing, some of these medications can't be stopped. They really do require interval dose reductions, and harnessing the powers of the post-acute care setting can be quite advantageous. Something that was unique about our study is we didn't just use explicit criteria. We had a patient-centered implicit deprescribing. I'll talk about our framework in a second. Ours was pharmacist and advanced practice driver driven. Physicians did not make any decisions with regards to making recommendations. However, the final decisions were the team's decisions. So that is something. All that we did from our study team was we offered recommendations to the team. We gave them rationale. We had discussions with patients and providers. And ultimately, all deprescribing decisions lived in the hands of the hospice or the post-acute care provider or the primary care provider after they were discharged. And finally, we did not focus on a single disease state. We took all patients who were going to post-acute care and we looked at all conditions. So this is one of the reasons why people would consider this a pragmatic trial. There are certain things that are not pragmatic about our study, but we're very generalizable with regards to the population that we were looking at. So this is a 5 years trial. It started in 2017, and it has completed an enrollment and follow-up, and we're still doing data analysis on certain parts, and I'll be sharing some new stuff that we're learning every day. The aims were we wanted to see, can we reduce the number of medications among patients prescribed, both at the hospital and skilled nursing facility discharge, and follow them up to 90 days to examine for sustainability. And secondarily, we looked at the intervention effects on geriatric syndromes, adherence, and functional health status. I don't have as much information about that yet. And we, of course, looked at patient safety outcomes as well. Our patient population, they were 50 years of age and older. They were taking 5 or more medications at the time before they came into the hospital. They were discharged to one of our 22 partner skilled nursing facilities. And these partners were the same facilities we worked with during our CMMI transitions of care study, just trying to improve those transitions of care. Home residents had to be within a 9-county area of Nashville because we were doing home visits at the 90-day site. I will let you know that those home visits stopped after COVID. So it was home visits for half the trial and all telephone visits for the second half of the trial. There were non-hospice patients. They had to be admitted from the community setting. This would include assisted living facilities. And they had to self-consent or have a surrogate available for consent. About a third of our patients did have surrogates. This is just a look. This is Nashville, Tennessee, where I came from before. And this is where our 22 facilities were looking. Just to remind people about skilled nursing, why is this an important population? 33% of hospitalized Medicare patients receive post-acute care. They take up a huge portion of resources from a standpoint of cost. And as I mentioned before already, this is a great venue to really kind of follow patients and potentially enhance and continue deprescribing. At least that's what our hypothesis was. This just shows the timeline of our study. You can see on the far left was phase 1. We would consent and do a baseline interview. We would be alerted of patients at the time they were referred to skilled nursing facility. Interestingly enough, when we designed the study, we based it on our CMMI study, and the time difference between alert and discharge shrunk by 50% in the meantime. So we really had to do a lot in a really small amount of time. We only had 1 to 2 days between skilled nursing facility referral to really do all this work before they went to the skilled nursing facility. So this was quite a heavy lift for our team. Among our intervention patients, both of our patients, to remind you, both underwent a best practice medication history, and I'll talk about that in a second. And then after that BPMH, patients underwent standard care for the control group versus a patient-centered interview where we would then initiate hospital deprescribing. We would then transition the patients to skilled nursing facilities. We would interact with those facilities on a weekly basis, not every day. We would make recommendations, and then the intervention ended at the time of discharge to the skilled nursing facility. We then contacted patients at 7 days, 60 days, and did a home visit for half the trial at upward 90 days. Our outcomes, our primary outcome was total number of medications. We wanted to make sure that could we actually do this? Can we reduce potentially inappropriate medications? Can we reduce the drug burden index and make it sustainable up to 90 days? Our safety measures, we looked at ED visits, hospital utilization, mortality, drug-related adverse events, as well as adverse drug withdrawal events. So do we cause any harm by stopping those medications? This is our population. And so you can see that it was predominantly female, predominantly white, an older population with an average, a median age of 76.8. Very highly comorbid. If you remember that Operam study, they took patients with 3 or more comorbidities. Our median comorbidity index was 6. And then interestingly, where I came up with my title is one of the issues you deal with, and we quickly realized was, we don't just have a polypharmacy problem. The proportion of patients that had more than one pharmacy was almost half. 46.2% of our patients were getting medications from more than one pharmacy. And you can see why we might miss medications if we don't reach out to all of them. The median number was 2. The number of outpatient prescribers that our patients were getting their prescriptions from was 3. So once again, if you're thinking about, am I capturing the medicines, but also from the complexity of deprescribing, this creates some challenges and problems potentially. Our patients were commonly getting help with medication management. This was an open-ended question, just are you getting any assistance? That could be anything from someone going to help pick up your medicines to help administer your medicines at home. And then the total pre-hospital medications from all sources was 16. You can see, if you remember that first study I showed, which was based on our CMMI, that was 15. And that's because we did a better job of actually reaching out to those resources and we're picking up medications which we didn't pick up on that CMMI study. Now, just to show you that in the drop med population, this was a VA population, which we are just wrapping up the study right now. And you can see very similar information. The number of outpatient prescribers among our VA population, 3. The median number of pharmacies, 2. And the number of pre-hospital medications, even a little bit greater at 17. So this is quite a problem of polypharmacy, polyprovider, and polypharmacies. Now, this just takes you through our deprescribing steps. We do a baseline interview, and then we have clinicians pre-review the medicines and make recommendations. One of the most important steps if you want to do effective medication management is you do have to do a best possible medication history. Now, what's the definition of that? It really means you're using 2 or more independent sources to come up with your medication list. And often what's happening is in that first box in the far left is your EMR will have a default medication list that's already in there as soon as they're admitted. And that's what our comparison was with regards to, and that's what most people use when patients get admitted. However, we would also do each of these additional steps. We did a bedside interview and we gathered a list of their pharmacies, their prescribers, and gathered all the other medications that they were taking. We asked them to bring them from home if they could, or lists from home. We looked at all their pharmacies and we asked for refill history. We then looked at the Tennessee Controlled Substance Monitoring Database to find any additional medicines or prescribers. And then we would take any ancillary medicine records, of course, if they had any history of being transferred from an outside hospital or skilled nursing facility or the such, we would take a look at those records as well and come up with the final gold standard list. I put a resource here. Marquee is some great work that my colleagues have done through Society of Hospital Medicine, really kind of putting real teeth behind best practices and medication reconciliation and taking a great medicine history. And this was our framework from a standpoint of how we thought about deprescribing. On the far left, you can see that we have a situation with inappropriate deprescribing. Most studies, you would start up on the top. They would look at medication-specific factors with things like the Beers list and the start-stop list. And those are based on drug-drug interactions, drug-disease interactions, and potentially inappropriate medications. That's what I would call structured deprescribing. However, we also added on the bottom those notions of goals of care, life benefit, life expectancy, appropriate treatment targets, adherence, cost, all those additional patient and disease factors, providing that patient preference context, moving ourselves to the right, where we would have what I call patient-centered reductions in medications. And our goal is, can we kind of reduce geriatric syndromes, improve adherence, and improve healthcare? Now, I talked a little bit about those indications for deprescribing. What we would do when we reviewed the medications is we would ask our advanced practice provider or pharmacist to come up with at least one indication. Sometimes there would be multiple, but they were not required to list multiple. The most frequent for us, once again, was no indication for medications. For us, it was 39%, actually a little bit higher than that operand study. Inappropriate for the current indication. The medication had uncertain effectiveness, duplicate medication, 1 second here, I'm just going to shrink this here. Higher risk medications inconsistent with goals of care, poor adherence. And for us, no indication was the most common. Medications on the stop Beers list accounted for 25% of our rationales. Patients reporting not taking the medication, although we had on the list, was 15%. Duplicate medications for the same indication, which we thought it was inappropriate, was 12.9%. Drug disease interactions, 12.7%. And then some of them were just indicated for a short time, but were kept on longer than that. So we would then do a patient preference interview, and we would ask them about their medication knowledge. Are they adherent to the medications? Are they having side effects? Do they want to stop the medicines? And what's their willingness to decrease the dose for specific medicines? But really simple questions that were adapted from the brief medicine questionnaire. And really just like, why are you taking the medicine? How well does this medicine work for you? Does it bother you? Have you missed taking the medicine in the past month, past days? And we would ask these questions and try to put together. We also used something called the patient attitudes towards deprescribing and acute care. And this is just a list of simple questions, but I think this is really interesting with regards to how our patients are thinking about their medications and our role as providers. The first is, I feel I'm taking a large number of medicines, and among our shed meds population, 70.8% said yes. However, interestingly enough, a majority of patients said, I'm comfortable with the number of medicines I'm taking. So even though they're taking an average 16, more than half of them are comfortable, but 70% of them say they're taking a large number. And then 61% think that all their medicines are necessary. So to me, this means there is a lot of education which needs to be had from a standpoint of of identifying those patients which may not be necessary. And importantly, the role of physician. If my doctor said it was possible, I'd be willing to stop one of my medicines. 92.9% of them said yes. So our patients, they overall think they're taking a lot, but the majority think they're appropriate. But if we said that we would want to stop them, they would still believe us and trust us. And so there's a real important role for the physician, APP, and pharmacist in deprescribing. Now, how did we do? This just shows you among our patient population, 177 patients for which we were able to have patient preference discussions in the intervention arm. We discussed 1,405 medications. And you can see that the most commonly discussed medications were diabetes medications and vitamins and supplements. Interestingly, you'll note at the bottom row, anxiety medications, for example, benzodiazepines, there was a smaller number, but we were actually much more successful. Our patients were far more agreeable to deprescribe a benzodiazepine than if you look at the third row, vitamins and supplements. Only half of our patients were willing to deprescribe those vitamins and supplements. And there's a kind of an interesting story there. And our diabetes medicines, about 2/3 of the time, or 3/4 of our time, our patients were willing to deprescribe those medicines. That doesn't mean we did deprescribing. It just meant that we thought that they should be deprescribed, and the patient thought they were okay with them being deprescribed. Now, we would typically not deprescribe a medicine or recommend it if our patient was not willing, because we knew that is not going to be a sustainable solution. And we were really looking for sustainable deprescribing. And so our next step is, well, we need to talk to the providers. And so we tried to engage all outpatient prescribers for which we were going to deprescribe a medication. And here you can see in the intervention group, we had a total of 186 patients. I mentioned before, we were able to complete deprescribing interviews for 177, but only 134 did we actually have to have deprescribing conversations, because some of them, there was no medicines to talk about. That there was just no there, or the patients were unwilling to deprescribe, in a small number who withdrew from the study. So among those final 134, we were able to contact 75% of outpatient providers. And so the flip side might be, well, we weren't able to contact 25% providers. And this is in the context of a well-resourced study for which we have people really trying hard to get a hold of these individuals to engage in deprescribing conversations. So this to me means, it can be done, but boy, it's not easy. And when we were able to talk with a provider, 4 to 5 medicines were discussed. Patients, just going back to this, our outpatient prescribers, as mentioned, we spoke to 75% of them, and they were agreeable to about three-quarters of our recommendations. So 77% of the time, they were agreeable. And the most common reason was tacit agreement. They just said, we trust you, and didn't want to have a lot of discussion. But more to come from this. So we talked to the patients, we talked to the providers, and after we talked to both of them, we would then offer up those recommendations to the primary team and go ahead and do deprescribing actions. Now, how did we come up with deprescribing actions? Well, we didn't invent them ourselves. There's a lot of great work being done in this area. And if you're interested, deprescribing.org is a wonderful site. They have structured evidence-based guidelines for deprescribing for PPIs, benzos, antihyperglycemics, antipsychotics, and cholinesterase inhibitors. And we utilized a lot of this. Some of it's been developed since the time that we did this trial. I'll just point yourself also to the US Deprescribing Network. This is a research network among those of us. It just started after we did this trial, but they also have a lot of resources for clinicians, deprescribing guidelines, videos, and general approaches. So if you want to learn more, please go to deprescribingresearch.org. Now, deprescribing, once again, it does not mean stopping the medicine. It can stop now at discharge, stop and monitor, stop later, titrate down, decrease the dose, decrease and monitor. And then sometimes we would not recommend deprescribing, continue. Sometimes we'd recommend adding a medicine, or obviously put it currently on hold, but it should be restarted when they're an outpatient. If we're holding their ACE inhibitor, we would point out that this medicine should be restarted at the time of discharge. All right, so let's just get on to how we did and what happened at the end of these studies. So just to let you know what our process at the time of hospital discharge, we would do a warm handoff with skilled nursing providers. We ensured the correct lists, we communicated our deprescribing recommendations, And as I mentioned, we would call once weekly and contact the advanced practice provider or pharmacist at the facility and just ask them what medications are they on right now, and then continue to make recommendations depending on what their list was at that time. And at the time of skilled nursing facility discharge, we created a comprehensive list that we shared with all outpatient providers. It included what they were on, what had been stopped, why it had been stopped. We also talked about any adherence issues and further deprescribing recommendations that we would recommend down the road. Importantly, I put in bold, we canceled refills of all stopped medications because what we didn't want is patients to go home and then the medications show up back at the door. So this is what happened at the end of the study. So this study, of course, has finished up enrollment and the 90-day follow-up. And what we found was among those medication outcomes, we were able to successfully reduce those medications. You'll notice on the kind of where we trial enrollment, here, this is when we actually saw the patients a couple days before discharge when they were referred. And you can see they're on a whole host of additional medicines. And these are all the medicines that we add, those laxatives and vitamins and things like that. But the reason we did this is we said, we want the enrollment medication list to be any medicine that they could potentially be deprescribed on. So that would include any pre-hospital medicine and any new medicine that they got while they're in the hospital, which could be continued. And you can see that there was tight correlation, obviously, in balance between those populations from the intervention control. You can see that there's not a huge difference at hospital discharge. And part of that's because we just had such a small amount of time to successfully deprescribe. We had an average of 1 to 2 days between SNF referral and discharge. But then we started to have dramatic differences at post-acute facility discharge with about 3 medication difference by the time that they're at 90 days. Now, I just bring this is our VA population. This is unpublished. We're just finished this up. The VA population, we actually have a lot more time in the hospital to work with them. The time from SNF discharge to skilled nursing facility tended to be in the order of multiple days, not just 1 or 2 days. However, we did not continue deprescribing in post-acute care. So you can see here in VA drop, there was a much bigger difference at hospital discharge, but really it just stayed consistent and no further decrease in post-acute care, which is not all that surprising because we didn't do any more active deprescribing. So to me, this just shows the importance of that continued deprescribing in post-acute care when possible. Now, what were the medications that we deprescribed? The most common were vitamins. You can see that in the gray is stopped, in black is reduction. The majority of medicines that we deprescribed actually were stopped. And this was stopped by 90 days. And so we made us stop them by now, but by the time of 90 days, vitamins and supplements and laxatives were the most common, but you can see number 3, antihypertensives, anticoagulants, non-opioid analgesics, opioid analgesics, diabetes drugs, antiemetics, antibiotics, and hypoglycemics. And this just shows that it wasn't just vitamins and supplements that were driving some of the reductions. Our potentially inappropriate medications went down by about 2 medications by 90 days. And our drug burden index, remember, a reduction of a 0.1 means a really high dose of a large anticholinergic or set of medicines, or potentially 2 medications at lower doses. And at 90 days, we had about a reduction of 1. All of these effects were statistically significant over the course of 90 days. There were no changes in terms of no statistically significant differences in terms of ED visits, hospitalization, death, and ICU transfer. And there was no statistically differences in adverse drug events. All of the differences did favor the intervention. However, we were, of course, not powered to see any differences from this perspective. But others have taken our data already and combined it with others in the sense of meta-analysis. This is looking at readmission. And you can see most of these trials have been conducted since 2017 when we conducted our trial. And you can see that there was overall about a 15% hazard reduction in readmission in this meta-analysis looking at inpatient deprescribing. All right, we're going to wrap things up. Case resolution from that I showed you. So if you remember, I had that 54-year-old woman with lupus, and this is a patient I saw, and this was in my note. I pulled this from my note. I said, I added a new problem called polypharmacy. I said I discussed hyperpolypharmacy with numerous sedative, hypnotic, and psychoactive medications that have high potential role for patients' recent fall and debility. Many of these medications in discussion, for example, Lyrica and Robaxin, were added during an acute medical crisis. However, they were never titrated back to off. Most concerning medications included the following. I listed a long list of medications. For now, the patient was willing to begin titrating down on some medications with further reductions that can occur in rehab to follow up. For the first steps, I reduced her clonazepam from 2 milligrams to 1.5, reduced her pregabalins to 75 milligrams twice daily from 3 times daily, changed her methocarbamol from scheduled to as needed, and I just prescribed naloxone at the time of discharge. We established primary care for her. We arranged follow-up with rheumatology and pain clinics. And I followed up on this patient, and we gave kind of further deprescribing instructions in our discharge summary. And by the time she had followed up, her Benadryl had been stopped and replaced with loratadine. Her clonazepam was now down to 1 milligram. Hydromorphone had been decreased from 4 milligrams to 2. Naproxen still stayed off. Methocarbamol continued as needed. Pregabalin was now down to daily from 3 times daily. Her prednisone was decreased to 50 milligrams with rheumatology's plans to titrate to a steroid-sparing immunosuppression. And she was referred to neurology for consideration of deprescribing carbamazepine. So to conclude, hopefully I convinced you that there is an issue of polypharmacy, polyproviders, and polypharmacies. These are all widely prevalent, and they predict multiple medication discrepancies, especially omissions, as well as a wide array of poor clinical outcomes. Patients are interested in deprescribing when there's appropriate clinical guidance and shared decision-making. And the lack of medication indication is the most common reason for deprescribing in the acute care setting. I believe we can safely reduce medication burden in the acute care setting. And I also believe that the skilled nursing facility setting is a wonderful place and opportunity to continue this deprescribing when possible and feasible. I do want to thank a whole bunch of members on our research team in both the SHEDMEDS and DROP-MED team. We, of course, wouldn't do this without the support of the NIH, the VA, both of us who have supported us, and those as well as CMS, which really got us started with that CMMI project. So with that, we'll take questions.
Great. Blair, do you want to moderate in the Q&A? There's a bunch.
Yeah, absolutely. So we have a bunch of kind of questions have come in through kind of the chat, I think, about a lot of interest in your work. So one of the questions I wanted to start off with, which was from Philip Cohen, was about patients with multiple subspecialty clinics, kind of each prescribing. And I think we oftentimes see this in hospital medicine, as it's not even clear who necessarily owns a medicine. And I was wondering how your team kind of approached that.
Yes. So as I mentioned, we had a median of 3 different prescribers. What you found was the most common people we talked to were primary care clinicians and geriatricians. So some of those multiple subspecialty medications, we knew that they'd be more complicated to deprescribe, but it didn't mean that we did not deprescribe them. A common reason, for instance, was amiodarone. Amiodarone was one, but we would not deprescribe it unless we talked to a cardiologist. If there was an anti-seizure medicine, we for sure we would talk to the primary prescriber of those medicines. But we couldn't do everything at once. So we would say, where do we get the most bang for the buck? And we found the primary care clinician and the geriatric specialists were the best source to be able to start that deprescribing.
And then there were a couple questions about the best practice medication history and kind of some specifics. So 2 of the questions, one is about whether you were always able to call a pharmacy and actually verify like last fill date and so forth. And then the second really
100%.
Okay, that's great. And then were you able to ever kind of obtain collateral from kind of patients' home about were other people using the medication, or were they getting it from family members, and kind of additional insight into that?
No, really good question. So even our best practice medication history, we understand it's still not the gold standard. What's the gold standard? It's what's actually in the blood of your patients when they come to the hospital. And in fact, I'm working with a collaborator where we're doing just that, where we're looking at mass spectroscopy to look at patients who come into the hospital to get measurements so we can actually find out what our patients are taking. And then that can stimulate some further conversations. We definitely use collateral information from providers and caregivers and encourage people to bring in their medications when possible. Furthermore, one thing, just a shout out to Michelle Twee, who's here, as well as Josh Shapiro on our hospital home program. I'm really interested in looking at the hospital at home space as well from a standpoint, because guess what? You're in the home. We can actually find out where patients are storing their medicines, how they're storing them. There's a lot more information that can be gained from the home setting. So completely agree. So our best practice is still not even the gold standard.
I wanted to ask a related question from Steve Barcy that I think is really important about caregivers. He says many of our older patients, our medically complex younger patients, work closely with family members and care partners to manage their medications, especially those with cognitive impairment. Obviously, these advocates play a pivotal role in communicating with ALFs and PCPs. And so how did you engage that group in terms of some of the deprescribing plans?
Great point. So 1/3 of our patients had caregiver engagement. Half of them completely depended upon their caregivers for that decision making. If you remember, I showed you the attitudes towards deprescribing. There was zero differences between the patients and the caregivers, with one exception. The only exception was with regards to their sense of how much cost should play into it. The caregivers were actually less sensitive towards cost than the patients themselves. But otherwise, the caregivers were crucial, but their behaviors and attitudes towards deprescribing, at least in our trials, were very similar. But they're also an incredibly important group to engage, because I showed you 65% of the time, they're engaged in some point. Our patients are getting help with medication management in one form or another.
Great. We got a comment from Betsy Trowbridge, which I had forgotten about, that we're starting a SNFs program January 1. So that's an exciting opportunity to
I
think
need to
about.
connect with them for sure. So Betsy, send me the information, please.
One question from Elizabeth Chapman was, how do you make deprescribing in the hospital feasible outside of a study when our pharmacist productivity is measured with admissions and discharges and the physicians are extremely busy? Essentially, how do you convince a health system to put resources towards this work?
Yeah, so obviously there's a lot of work that needs to be done from a standpoint of kind of the ROI. Are we actually able to create differences? I showed you we were able to reduce about 3 medications. In the skilled nursing facility, guess who pays for the medications? The skilled nursing facilities do. So there's huge incentive for skilled nursing facilities to reduce the burden of medications, because they are ultimately the ones comes out of their pocketbook. So engagement of skilled nursing facilities actually may be easier than in the hospital, because in the hospital we do not pay for those medications. But for your observation level patients, guess who pays for those medications? Your patients do. And so there's an ROI from your patient perspective. But I think we need to show more that this creates real benefits from a standpoint of geriatric syndromes, readmissions, et cetera, et cetera.
Well, can I make a little PSA or pitch? So you talked about patients often have multiple pharmacies where they're getting their medications from. I think one opportunity, particularly in the inpatient service for discharge, is to talk to the patients about consolidating their prescriptions even at the UW pharmacy, because we can deliver their discharge medication at the bedside and they can get them all delivered by mail. And it just really simplifies the system. And I think that's another missed opportunity for us.
What a great point. We did not do that at all. We did not try to change their pharmacy behavior, but clearly the polypharmacies behavior, in my mind, is an issue. And at the VA, our DropMed study, our patients are definitely using multiple providers and pharmacies, and also the providers aren't even in the same system now, right? Because of choice, they're going all over the place.
Yeah, no, that's really important. I think one of the other kind of questions that came, I think is related, is are there opportunities to kind of partner with community in-home paramedicine programs before the patient gets inpatient? And had you guys thought about that? And kind of, can you speak to that?
Yeah, I mean, I definitely, when I interviewed here, I remember meeting with Manish Shah, who used a lot of paramedicine in his work with dementia. And it was something where I've been meaning to connect with him to say, I want to go on these paramedicine visits and see what and how they do it and how we can kind of do something more. Because we stopped at skilled nursing facility discharge. The only reason we stopped is because we didn't have money to do it more. We knew that we would love to continue the deprescribing, but we couldn't afford to do it. And paramedicine might be one of those ways to continue that process.
Great. Well, maybe one last question, which was just, how did you guys actually define duplicate medicine? So someone mentioned kind of were PPIs and H2 blockers, kind of, can you kind of speak to that?
Yeah, so I mean, we basically used FDA classifications with regards to so antihypertensives, beta blockers, calcium channel blockers, and so sometimes things did mix. Of course, you might be on an ACE for your heart failure, not your antihypertensive, and so we just had to make a choice. So if you just look at the FDI common classification list, that's how we did our definitions of what class they were in.
Great. Well, I think we're just about at time. For additional questions, please reach out to Dr. Vasilevskis. He is here all the time, well, most of the time. And I know he'd be delighted to hear from all of you for any questions or potential collaborations. Thank you for a great overview and insight into polypharmacies and opportunities for us to engage and improve the health of our patients. I mean, I think that's the other argument for the health system. And ultimately,
Yes.
is, if we can decrease readmission rates from medication errors, et cetera, that's good for everybody.
Well, great. Well, thank you all. I really appreciate being here. And so definitely reach out if anybody has any interest. I would love to hear from you.